Hi everyone. Today I am discussing about occupational therapy for Parkinson's disease. This presentation is for anyone who is interested in occupational therapy, like occupational therapy students, occupational therapy practitioners, as well as other rehabilitation professionals. I am Phinoj K. Abraham. I am an occupational therapist for the past 16 years. You might be knowing that April 11th was observed as World Parkinson's Disease Day. This year's theme was Share Your Spark, Help End Parkinson's Disease. To spark our discussion, let me share one case study that was done in the UK back in 2003. The aim of this survey was to understand the practice pattern of occupational therapists for Parkinson's disease. This survey demonstrated three interesting findings. Number one, OTs emphasized self-care over occupational performance, which is the core of occupational therapy. Second, occupational therapists lacked knowledge in condition-specific or stage-specific interventions for Parkinson's disease. As you know, Parkinson's disease progress through stages. Most of the time, occupational therapists lacked knowledge how to address various stages. Third, OTs expressed a need for more training to address occupational performance. We often address problems related to self-care performance rather than the occupational performance. So the gap seems that many times we miss out to address the occupational performance of persons with Parkinson's disease. So the aim of this presentation is to address this gap by identifying the impact of Parkinson's disease on clients' occupational performance and quality of life. Second, to analyze a framework for occupational therapy interventions in Parkinson's disease and explore evidence-based occupational therapy interventions for managing Parkinson's disease symptoms. I have no conflict of interest in this presentation. Let's look at the Parkinson's disease. Parkinson's disease is often defined as a progressive neurodegenerative disorder that affects the basal ganglia, characterized by the onset of tremor, muscle rigidity, slowness in movement, and stooped posture. The traditional definitions like this only address the motor symptom of Parkinson's disease. In reality, Parkinson's disease have both motor and non-motor symptoms. So let us look at the symptoms of Parkinson's disease to understand this concept more. Symptoms of Parkinson's disease under motor symptoms, we have bradykinesia, hypokinesia, akinesia, rigidity, rest tremor, postural instability. The first three, bradykinesia, hypokinesia, and akinesia, often professionals use interchangeably. However, there is a difference between these three terminologies. Let me explain it with a small example. Bradykinesia is the slowness of movement. Here, the person will be able to complete the task. Let's say, for example, if the person wants to drink water from a glass, he may be able to perform the task, but with a slow pace. Whereas with hypokinesia, the person may be able to initiate the movement, however, he might not be able to complete the movement. When it comes to akinesia, there will be inability or very difficulty to initiate the movement itself. These are the difference between these three terminologies. This is very important in our day-to-day practice because quite often our patients may stuck with one of these symptoms. This time, so it is very important for the occupational therapist to use right terminology to express the current functional status of person to others. Coming to the rigidity, rigidity is the presence of abnormal tone in both agonist and antagonist. In Parkinson's disease, one type called cogwheel rigidity is most common. Rest tremor. Resting tremor is a peculiar feature of Parkinson's disease where the tremor will be predominant when the patient is at rest. And postural instability. Postural instability includes loss of balance, the difficulty with walking, something called Festinant gait. All these symptoms are associated with that. So these are the major motor symptoms exhibited by Parkinson's disease. Now let's look at the non-motor symptoms. Non-motor symptoms include cognitive dysfunctions, emotional and neuropsychiatric problems, autonomic failure like sweating, incontinence, sexual health issues, fatigue, pain, sleep disturbance, dementia. Remember our discussion, many times these non-motor symptoms appears before the motor symptoms. However, because of the definition, the clinicians often ignore or unintentionally ignore these non-motor symptoms. As occupational therapists, we must keep this point in our mind while we assess the patients. We should not limit our assessment only with motor symptoms, but also we should assess or we should pay equal attention to the non-motor symptoms. Coming to the prevalence and incidence of Parkinson's disease. Parkinson's disease affects over 10 million people worldwide, with nearly 1 million in the US itself, and expected to raise 1.2 million by 2030. Incidence of PD has been increased by 50%, with around 90,000 new diagnoses annually in the US. Men's have 1.5 times higher incidence and prevalence of Parkinson's disease. In summary, Parkinson's disease is a growing public health concern with hundreds of thousands of new diagnoses each year in US itself. Some quick facts about Parkinson's disease. Parkinson's disease is the most common cause of Parkinsonism. Risk factors include age, genetics, gender, and environment factors. PD remains incurable but treatable. The disease progresses in stages, with symptoms gradually worsening over time. The disease causes not only motor symptoms but also cognitive, emotional, and other symptoms impacting quality of life. PD is often accompanied by social stigma and discrimination. Now let's discuss about the difference between Parkinsonism and Parkinson's disease, or is there any difference between these two terminologies? This flowchart will grossly give an idea about the Parkinsonism. As you can see here, Parkinsonism in fact is an umbrella term which includes both primary Parkinsonism and secondary Parkinsonism. Primary Parkinsonism means the Parkinsonism where the cause is unknown, or in other words, idiopathic or sporadic onset. In secondary Parkinsonism, the cause is often known, such as drug-induced Parkinsonism, trauma-induced Parkinsonism, or vascular insult-induced Parkinsonism, etc. As you can see here, primary Parkinsonism consists of Parkinson's disease as well as atypical Parkinsonism. Parkinson's disease itself makes 75 to 80% of Parkinsonism. The difference between these two are Parkinson's disease causes symptoms we discussed earlier, whereas atypical Parkinsonism, in addition to the symptoms we discussed, it may come with dementia, hallucination, and other autonomic symptoms. In addition, the progression of Parkinson's disease is slow when compared to atypical Parkinsonism. And the most important difference is, the clinical difference is that Parkinson's disease often respond well to levodopa therapy, which we will be discussing later, whereas atypical Parkinsonism will not respond that effectively with levodopa therapy. These are the difference between Parkinsonism disease and Parkinson's disease as well as atypical Parkinsonism. Let's move on to the pathophysiology of Parkinson's disease. Pathogenesis of Parkinson's disease remains unclear. It is believed that degeneration of basal ganglia causes Parkinson's disease. Now let's look at the functions of basal ganglia. Basal ganglia is function as autopilot, which controls well-learned voluntary and semi-automatic motor skills and movements. Let me explain the function of basal ganglia with a simple example. Those who drive, they know that many times whenever you drive in a familiar route, and if there is nothing unusual happen, you don't even pay much attention in your driving process. You might not be remembering when did you pass across the signal or which gear you used, etc. Similarly, a well-learned activity or well-learned task, In order to carry out that task, you need not to put a lot of conscious effort. Much of the task comes automatically. This automaticity actually comes from basal ganglia. Dopamine is the major neurochemical messenger which facilitate the function of basal ganglia. Dopamine not only control the motor process but also control the cognitive processes such as attention, drive, motivation, mood, problem solving, decision making, visual perception, etc. Dopamine deficiency in Parkinson's disease disrupts basal ganglia function, which leads to the symptoms what we discussed earlier in Parkinson's disease. The pathophysiology of Parkinson's disease is not this simple. In order to understand the pathophysiology, I would recommend you to go through this particular article. It explains very well about the recent understanding about the causes of Parkinson's disease. Let's discuss the staging of Parkinson's disease. Hoyen and Dr. introduced 5 staging systems to define the progress of Parkinson's disease. The stage 1 includes the person exhibit mild symptoms such as unilateral tremor, which often will not affect the day-to-day functions. When it comes to stage 2, which is early to mid stage, more noticeable motor symptoms present bilaterally. Daily activities become more challenging, but still the person will be able to independently carry out the day-to-day activities. In stage 3, increased risk for fall due to balance problem, ADL become more challenging. However, the person can still be independent in daily activities. In stage 4 or the late stage, assistance required for ambulation. Dysphagia may be present, full-time help may be required. In the stage 5, which is the last stage, requires use of wheelchair or the person may be bedridden. Here, constant nursing care is necessary. Cognitive and neuropsychiatric symptoms may also present. Kindly note that the early, mid, late terminology is not part of this Hoyen and Dr. staging system. I have added this terminology for future discussion in this presentation. Let's look at the Hoyen and Dr. staging system and premotor stage of Parkinson's disease. As you can notice here, Hoyen and Dr. staging system based solely on observable motor symptoms. Whereas premotor stage of Parkinson's disease occurs before diagnosis of Parkinson's disease and other motor symptoms. These symptoms include loss of sense of smell, rapid eye movement, sleep disturbance, constipations, etc. In order to understand this topic, I would recommend you to go through this particular article. Now let's discuss about the medical management briefly. There are two types of management, medication as well as surgery. Under medication, the first line drug is levodopa. It often given in combination with the drug carbidopa to reduce nausea. With the use of levodopa, there can be on and off times in the person's symptom. This means that whenever the effect of levodopa is in the body, active in the body, the symptoms will be reduced and person may be able to function quite normally. But as and when the effect of levodopa reduces in the body, the symptoms suddenly started appear. This may be challenging for the person. There may be sudden freezing of movement, slowness of movement, and exacerbation of all other symptoms. This is often a difficult time for the person to manage. The other medicines are like dopamine agonist, amantadine, adenosine A2A antagonist, anticholinergic drugs, etc. Coming to the surgery, deep brain stimulation is a relatively new and very popular surgical method to address Parkinson's disease surgically. Most it mostly addresses the movement symptoms like tremor, dyskinesia, etc. The benefits last at least 5 years. The other surgical option is DIOPA. This is similar to the baclofen pump. It allows slow release of carbidopa and levodopa to the small intestine. The key advantage of this method is that it can overcome or it can reduce the on and off times caused by levodopa. So it can be a better alternative for levodopa. Other surgical options include thalamotomy, pallidotomy, subthalatommy, etc. Let's summarize what we discussed so far. Parkinson's disease is a progressive and incurable but treatable neurodegenerative disorder. It goes beyond motor symptoms. It can also affect cognition, emotion, and other areas of life, impacting quality of life even before motor symptoms appear. Now let's move on to impact of Parkinson's disease on occupational profile. Let's first discuss about the need of a conceptual model. A conceptual model, as you know, provides broader structure to understand a concept. It can help occupational therapists to have a holistic view of occupational performance. This considers the person, task, environment, etc. It also helps the occupational therapist to plan intervention addressing all these domains, such as activity limitation, participation restriction, etc. However, our models often have a challenge. The challenge is that occupational therapy models are often jargon heavy, and this creates communication barrier for other disciplines unfamiliar with specific terminology of occupational therapy. So that interdisciplinary communications with our terminology would be difficult with the use of our models. So one possible solution is that an interdisciplinary conceptual model that can facilitate communication and collaboration between OTs, clients, caregivers, and other healthcare professionals. ICF, International Classification of Functioning, Disability and Health, is a biopsychosocial model of functioning, disability and health by WHO. This is the conceptual model of ICF. ICF outlines the health conditions interaction with various other key components like body functions and structure, activities and participation, then contextual factors like environmental factors and personal factors. Let's discuss one by one in brief. Body function and structure means this is our physiological as well as anatomical functions. Range of motion, muscle power, voluntary motor control, etc. comes under the body function and structure domain. When it comes to the activities, this is the person's ability to carry out an activity in an ideal environment. Participation means a person's actual participation in his real environment. As OTs, we know that the person's ideal performance might not be reflecting in his real environment. So ICF outlines these differences in this model. The contextual factors like environmental factors includes not only the physical environment but also the social, societal, attitudinal, etc. Personal factors include the family support, his own psychological status, etc. All these factors can impact the person's functional ability. Let's say, for example, two persons with Parkinson's disease, let's say they have same capability or same level of function. One resides in city, another one resides in a rural area. Because of the environment and probably the personal factors, their level of participation in real life would be different. Here, this is not only the disease stage, but actually the environmental factors and the personal factors made the difference. ICF help us to understand the health condition from all these perspectives. Parkinson's disease affects people differently, so occupational therapists need to consider each person's unique situation. ICF helps it. Although ICF is a good tool to understand the health from various perspectives, ICL, to my opinion, have some limitation. For example, the distinctive difference between activity and participation is not that clear when it comes to the real practice. Second, the domain quality of life, which is not mentioned in this model. If there is, whenever there is an impact on body structure, activities, and participation, it also reflects on the quality of life. However, this domain is not addressed in ICF. Now let's move on to the assessment tools. OTs use various standardized and non-standardized assessment tools to address the level of functioning of persons with Parkinson's disease. In order to understand the disease severity, Hoyne and Yar classifications which we discussed earlier is a useful tool. In order to understand the impairment level, Unified Parkinson's Disease Rating Scale, Movement Disorder Society Unified Parkinson's Disease Rating Scales are two good scales. In order to assess the activity limitation and participation restriction, Functional Independence Measure, Patient-Centered Occupational Performance Measure are two good tools to be used. In order to assess the quality of life, Parkinson's Disease Questionnaire or short form 36 are other good tools that can be used. Now let's discuss the impact of Parkinson's disease on activity and participation. Number one, increased stiffness and reduced trunk flexibility. It can have an impact like difficulty turning, moving in bed, performing daily activities, transferring, driving, socializing, and living independently. Second, gait and balance problem. Symptoms include start hesitation, shuffling gait, slowness, festination, freezing episodes, postural instability. This can impact initiating walking, increased risk of tripping, reduced walking speed, impaired coordination during turns, increased risk of falls. The third impairment is reduced manual dexterity, poor coordination, and tremor. It impacts difficulty with daily tasks like eating, dressing, applying makeup, and writing. Dysarthria. It may lead to poor breath support, loss of voice clarity, decreased speech intelligibility, reduced volume. It impacts difficulty in communication. Fatigue. Fatigue is a common symptom in Parkinson's disease. It impacts reduced endurance for daily activities. Cognitive changes. This results in slowed thinking. This is also called as bradyphrenia, difficulty with problem solving and decision making, reduced concentration, apathy leading to social isolation, low mood, difficulty managing roles at home, work, and social. Let's discuss about the impact of environmental and personal factors. Environmental factors first. Home safety. Poorly lit areas, loose rugs, and cluttered space can increase the risk of fall. Accessibility. Difficulty navigating stairs, narrow doorways, or lack of grab bars can limit mobility and independence. Social settings. Noisy environments can worsen the communication difficulties. It negatively impacts the performance speed, especially with the motor task. Coming to the personal factors, age. Symptoms often worse with age. Severity of disease. The degree of dopamine loss impact the severity of symptoms and limitation. Cognitive status. Pre-existing cognitive decline can be increased by Parkinson's, further impacting daily activities. Motivation and coping skills. A person's outlook and ability to adapt to limitations can significantly affect their quality of life. These are some of the impact of environment and personal factors. Now let's summarize what we discussed so far. The ICF is a valuable conceptual model that OTs and other interdisciplinary professionals can use to understand the impact of Parkinson's disease holistically and plan interventions collaboratively. This is a suggestive reading in order to understand how OT and PT can use ICF in their treatment planning. Let's move on to the OT management for Parkinson's disease. Let's move on to the occupational therapy management of Parkinson's disease. As outlined by the Cochrane review, the role of occupational therapists is to support the individual with Parkinson's disease and to enable them to maintain their usual level of occupational performance for as long as possible. Let's discuss some of the principles of OT interventions for Parkinson's disease. The first and foremost, early and proactive intervention. We must start our interventions as early as possible to prevent the problems get worse. The second principle, client-centered and evolving care. This means that the focus of our therapy must be on what important to the person and their caregivers. Also, as the disease evolves, our interventions also should be evolved. The third principle is holistic focus and employment of a wide range of interventions. This means that we must focus on the person as a whole, not just some of his symptoms or self-care. And we must use a wide range of interventions ranging from remediating to compensatory, depends upon the stages of Parkinson's disease. The fourth principle is collaborative goal setting with individual and caregiver with regular review. Person-centered care is the key here, because with better person-centered care, there will be better compliance to the therapy suggestion as well as the understanding from the person. The last principle is interdisciplinary collaboration. Interdisciplinary collaboration is the key in Parkinson's disease management. Often, we need collaborative and coordinated care from multiple rehabilitation professionals to help our individuals. So, an interdisciplinary collaboration is essential. When we discuss about early approach and evolving intervention, automatically some questions arises in our mind. What, when, how? Also, is there any guideline? Let's discuss one by one in the following section. Aims and dose of therapy across the stages of Parkinson's disease. In other words, what and when. We have discussed already the stages of Parkinson's disease. We have seen that the Hoyen and Ayers classifications, it can be also viewed as early stage, mid stage and late stage. Let's discuss the therapy aim in various stages. The aim of therapy can be different at various stages of the disease progression. For example, in early stage, the aim of therapy would be consultative and proactive therapy to prevent getting the symptoms worse. In the mid stage, the aim of therapy would be more of restoration. When it comes to the late stage, the aim of therapy will be more of skilled maintenance as well as end of care treatments. Coming to the dosage of therapy, based on the evidences, 1 to 4 sessions with 6 to 12 months re-evaluation is recommended in the early stage of Parkinson's disease. When it comes to the mid stage, 2 to 4 visits per week is recommended. When it comes to late stage, around 1 visit every 1 to 3 months in an ongoing manner is recommended by the evidences. This guideline, in addition to offer clinical guidance, it also equips OTs with evidence-based reasoning for prescribing optimal therapy dosage and frequencies for persons with Parkinson's disease, and it also helps us to explain our plan of care to various stakeholders like the patient's caregiver, our superiors, our department leads, etc. So from that angle, this reference as well as this model is very useful. Going to the OT intervention process, in other words, how we should provide our interventions, this review article by Jelka et al. Provide an overview, such as enter or initiate, then identify the stage of Parkinson's disease, then do an evaluation using standardized and non-standardized scales, then agree the objectives and plans with the person with Parkinson's disease as well as their caregivers, implement the treatment plan, monitor and modify as and when it is required, evaluate the outcome, and finally conclude or exit the therapy. Now we will be discussing more about the implementation plan. Let's discuss about the evidence-based OT interventions for Parkinson's disease. In early 2000s, there was limited research on specific occupational therapy interventions for Parkinson's disease. Focus was mostly on self-care and daily activities. But today, there are many researchers supports OT's value in Parkinson's rehabilitation. Studies shows positive results for individual and group interventions. These are some guidelines which help us to understand the latest evidences for the management of Parkinson's disease. These guidelines explains 4 dimensions of OT interventions. Let's discuss one by one. The first dimension is promoting lifelong well-being. This means that, as we know, the Parkinson's disease is a progressive disorder. So, the demand and challenges faced by the patients may vary in each stages. However, our prime focus should be on the person's well-being, optimizing overall health, promoting independence as well as quality of life. The second dimension of OT intervention is empowering movement. Movement difficulty is one of the major challenges faced by persons with Parkinson's disease. So, our one of the major dimensions of intervention will be focused on developing strategies to improve initiation, maintainability, and control of movement for daily activities. The third dimension of OT intervention is optimizing activity participation. Here, adapt tasks, environments, and routines to maximize engagement in meaningful occupation will be the aim of occupational therapy interventions. Coming to the fourth dimension, this is supporting end of life care. Here, as the disease progresses, the focus of occupational therapy will be on providing comfort, dignity, and continued participation in valued activities throughout the disease course. Now, let's discuss one by one. The first dimension, promoting lifelong well-being. Key areas of focus for OTs are self-efficacy and resilience, roles and relationship, sexual well-being and intimacy, work, social and recreational and leisure activities, community living skills and outdoor mobilities. So, how to address this area? To understand how to address this area, I would recommend you to go through this guideline. This is quite extensive yet simple to understand. In order to save timing in this presentation, I am not going into the depth of each domain because that will take a lot of time. Rather, I recommend you to go through this guideline. The second dimension for OT intervention is empowering movement. As we discussed earlier, Parkinson's disease have a huge impact on the quality of movement by person. So, major emphasis is required to address this dimension. So, we are discussing a little bit in detail about this dimension. The key principle for OT interventions are number one, conscious attention. When we discussed about the pathophysiology, we learned that the role of basal ganglia is somewhat like an autopilot system, which means that the well-learned movements can be performed automatically with the help of basal ganglia. With the Parkinson's disease, this automaticity is often get affected. When it comes to the well-learned movements, occupational therapists should emphasize the person that the person should pay more attention to the well-learned activity for its successful completion. The second principle is limiting multitasking. Multitasking majorly carried out with the help of basal ganglia. Like we discussed earlier, basal ganglia promote automaticity in the movement. This in turn helps in multitasking. With the Parkinson's disease, the ability of multitasking will be compromised. In this case, limiting multitasking is very important for the successful completion of activities, as occupational therapists must emphasize this point in their intervention. Coming to the third principle, which is cognitive and sensory cues, utilization of cue is scientifically proven as an effective tool to trigger and guide movement flow. We will be discussing this point little later. Let's continue with the other principle. The fourth principle is promote mental well-being. Through relaxation techniques, group program, referral to mental health services are helpful to promote mental well-being. A better mental well-being is helpful to promote the movement quality. Let's discuss some of the strategies for initiating and maintaining movement. Number one, cueing. Cueing, there are two types, intrinsic cues and extrinsic cues. Intrinsic cues are self-initiated cues like counting, self-talk, visualization, etc. Whereas extrinsic cues, with the help of external prompts like visual cues or verbal instruction, we can facilitate the movement. How does cues work? Visual, auditory or written cues draw attention to the desired movement goal, encouraging patients to perform tasks less automatically and with more control. Let me explain this concept with an example. Person with Parkinson's disease often faces a problem called micrographia. In that, person may start writing with bigger letters but eventually end up with very small letters. Here, in fact, the automaticity is impacting in a negative way. So, in such scenario, verbal cues like write bigger can help the person to pay attention to the task more consciously, and eventually he can modify his way of writing in the way he wants. Let's look into the detail. The cueing helps to bypass the underactive basal ganglia and activate alternative neural pathways, allowing for better movement. In other words, the autopilot system becomes manual control. This is how the person is able to write bigger with the help of a verbal cue. In addition, the cues can stimulate the neural network. Cues like visual guides or spoken instructions related to a specific movement can activate the brain networks responsible for that action. This leading to larger or more controlled movement. This is how the cues works. Continue with empowering movement, promoting new learning. In order to promote new learning, timing is very important. We should ensure that the training or the learning session is arranged when the patient is most alert. In other words, in the on state. This will promote learning. Family or carer involvement. Education and involvement of family or caregiver is very important in order to carry over the skills what the person learned into the real daily life. Minimizing distraction. Optimizing focus during assessment and intervention is very important because, like we discussed earlier, multitasking is a tough task for person with Parkinson's disease. Some of the instructional techniques include verbal instructions with keywords, visual demonstrations, guided mental rehearsal, hands-on guidance, backward chaining approach, cue cards for reminders, etc. In addition, encourage self-talk. Self-talk is proven to be effective to promote internalization of key movement steps while performing the action. Like we discussed earlier, the self-talk of writing bigger helps the person to write in a big letter. The third dimension of OT interventions are optimizing activity participation irrespective of the stage of disease progression. So the aim is that improving participation in meaningful occupation through adapting tasks and environments, modifying routines, utilizing assistive equipments. So here the emphasis is on encouraging activity participation, not on whether it is remedial intervention or compensatory intervention. Use whichever means is effective to the patient so that he can participate to the fullest. Key areas of focus are mobility, falls prevention, transfers, bed mobility, posture and seating, eating and drinking, self-care, domestic skills, fatigue management, handwriting and communication. Again, I would recommend you to go through that guideline for the exact details of how to provide intervention. The fourth dimension in Parkinson's disease care by occupational therapists is supporting end-of-life care. There are some focuses. Number one, focus on comfort and quality of life. The person must have reached to the later stage. We should emphasize more on comfort and quality of life of the person. Manage symptoms to maximize comfort and dignity. Facilitate enjoyable activities like whatever person likes, music, spending time outdoors or with friends, etc. Address complications of immobility like proper positioning, pressure care, tightness, contracture, deformity, etc. The second dimension is 24-hour posture and positioning. There should be a clear plan of positioning the person throughout the day because in the later stage, the person will be often bedridden or dependent on wheelchair. This can promote a lot of secondary complications like tightness, contracture, deformity. So proper positioning and posture will help to prevent all these secondary complications. Another dimension is that minimizing manual handling risk. Always remember that as the disease progresses, the burden of disease is not only on the person but also on the caregivers. So, the occupational therapist should assess the risk for transfers and other daily activities and provide appropriate equipments like lift hoist and training to the caregivers as well as patient himself to assist in these daily transfers and other tasks. This can help both the patient and their caregivers to protect themselves from many secondary injuries. Another area of focus is alternative living arrangement. When the disease progresses and reaches the very late stages, the occupational therapist can discuss the alternative living arrangement like assisted living facilities if staying home is difficult. These are the focus areas under the dimension of supporting end of life care. Now let's move on to some special consideration. One is that postoperative rehabilitation after deep brain stimulation surgery for movement disorder. The reason why I selected this area is deep brain stimulation surgery is very popular nowadays. Automatically, the question comes the role of occupational therapy and its effectiveness. Let's look at some evidences. The research I shared here shows that there is a level B evidence for occupational therapy's effectiveness in Parkinson's disease. When it comes to the level of evidence for Parkinson's disease patients after DBS, we have a level C evidence, which means that the OT interventions are possibly effective but limited data available. So, in summary, the evidence based on specific rehabilitation intervention is still very scarce but should be considerably improved in the next years. Let's summarize what we have discussed under the OT management so far. Evidence supports OT's role in Parkinson's disease rehab. There are growing research demonstrates the effectiveness of both individual and group interventions delivered by occupational therapists. Second, addressing multi-faced problem is a challenge. Current OT practice may not always address the occupational performance holistically. We OTs must look at the problems in a holistic way and formulate intervention plans accordingly. Third, ICF can act as a holistic lens. The ICF framework provides a comprehensive understanding of how PD impacts individuals. It can also facilitate interdisciplinary collaboration. Fourth, need of client-centered and stage-specific care. A therapy framework considering the different stages of Parkinson's disease can guide the development and delivery of targeted OT intervention specific to each patient's condition. So far, we have identified the impact of Parkinson's disease. We have discussed about ICF and how it can help us to understand the problem holistically. Also, we discussed about various evidence-based intervention that is helpful for a person with Parkinson's disease. Now, one important question remains: what next? As clinicians, or as OT students, or as a stakeholder, what we should do for the betterment of person with Parkinson's disease? Let us discuss this. As we discuss, the theme of World Parkinson's Disease Day is share your spark and help people with Parkinson's disease around you. How can we achieve this? I have 4 points to discuss with you. Number one, ignite innovation. What does this mean? It means develop a comprehensive Parkinson's disease rehab program addressing all aspects of occupational performance tailored to your local context. In order to have a sustainable model of service delivery, we have to develop a comprehensive rehabilitation program. When I say comprehensive rehabilitation program, it involves a process that addresses all the dimensions of occupational performance that can be followed by a group of occupational therapists in your area. As an enlightened occupational therapist, you must take initiative to develop such comprehensive program in your facility. When you develop such program, ensure that the program is reflecting or addressing the needs of your local context. The second point, spark collaboration. Formulate interdisciplinary clinics at your workplace to offer holistic care for people with Parkinson's disease. As we discussed earlier, the impact of Parkinson's disease is multi-phased. So, importance of interdisciplinary collaboration is key here. As occupational therapists, we should not only focus on occupational therapy interventions, we must ensure the interdisciplinary collaboration for the optimal occupational performance of our persons. Often, the interventions of multiple rehab professionals is essential for the optimal occupational performance. So, let us formulate interdisciplinary clinics and interdisciplinary processes at our workplace so that our person will get the best and they will be able to perform to the fullest in their occupational performance. The third point is fuel connection. Foster support groups and peer counseling interactions to empower social participation and well-being. As we know, support groups and peer counseling can give a lot more than what the therapist can give to the person. For a person with Parkinson's disease, someone else who is going through similar situation can be a factor of motivation. So, wherever possible, foster support groups and peer counseling. The fourth point, share your spark. Share your success stories through publication to inspire others. Share your success stories through publications as well as other platforms. This will inspire other like minded people and motivate them to follow your steps or even develop similar steps in their context. These are some of the small steps which will help eventually to help people with Parkinson's disease around us. If you have any questions related to this presentation so far, you can ask me in the inbox or in the comment section below. I will be sharing the link of this presentation in the description so that you can download this presentation. These are some of the suggested reading related to this presentations. I would like to thank Dr. Arun Kumar Malekhan, Principal of Savitha College of Occupational Therapy, to provide me an opportunity to present this topic in their 44th webinar. In fact, I presented this on 12th April. Because of some technical glitches from my side, the recording was not good, the audio was not audible properly. So I decided to re-record this presentation. This is my contact. You can contact me through email or via LinkedIn. Thank you for listening my presentation. I hope you had a wonderful learning. Thanks again.